Bismillahirrahmanirrahim. Assalamu alaikum everybody. I must congratulate the organizers of this conference under very trying circumstances. I'm sorry I can't be there in person because I have to go and attend a meeting. Ladies and gentlemen, thank you very much for asking me to talk on surgical complications, myths and realities. Surgical complications are there, and we have to live with it. We can minimize it, maybe we can't completely eradicate it. We have to learn from our errors. To cover up failures is therefore the biggest intellectual sin. One of the first thing that says in the Hippocratic Oath is that do no harm to any patient. Complications are an integral part of surgery. They do occur under best of circumstances and when least expected, and no surgeon is immune to this. And those who claim to be having no complications probably have done not enough. Ladies and gentlemen, complications occur not uncommonly, and they occur in twos and threes. No surgeon in this world can walk with his head high, according to one of my professors in the past. A surgeon should not only minutely dissect the human organs, but also reasons, events that lead to complications in surgery. New developments, new procedures, hence newer complications, like in ICU, cardiac surgery, and laparoscopic surgery. Failures in academia and law in other specialities can be compensated by a check, but not in medical field. The operating theatre is one of the highest risk areas for serious complications. And a recent study of 7,900 surgeons found that those who had experienced surgical errors during the past 3 months, had lower quality of life. Ladies and gentlemen, in surgery, and one should not think of the time. You should save it wherever you can, but not at the expense of quality. In his most famous mishap, this surgeon, Robert Liston from London, he took off a surgical assistant's fingers and he cut through the leg. He amputated the leg in 2.5 minutes, and during this course he amputated in addition the fingers of his young surgeon, who later on died in the war, and he also slashed through the coat tail of a distinguished surgical spectator, and all 3 of them died, and this is probably the only operation in surgical history with a 300% mortality. Pause karo.
Ready, sir.
And say go.
Go, sir.
Ladies and gentlemen, what's the genesis of these complications? Is basically experience, casualness, overconfidence, and a misfortune on the part of the surgeon, and personal egos that I must do this procedure this way, and denial and inadequate supervision. Now, surgical accidents do occur operating on the wrong side. Too much or too little anesthesia, leaving surgical implants inside, or incorrect procedures, unnecessary surgery, surgical errors, and I think one of the bottom line is that it's bypassing basic surgical principles. There are certain actual assistant forms Like a laceration of the liver is a very, very common thing. Or laceration of the spleen during the course of assistance is not, or diaphragm burns, or recurrent laryngeal nerve injuries. So there are quite a few examples where actual assistant faults are there, but most of the time it's your responsibility as a surgeon to look after these complications and avoid them. And you can have wrong injections, muscle relaxant as a diluent. I remember a few years ago, I was in Karachi examining the FCPS students, and one of the nurses in my unit in North Surgical Ward gave a muscle relaxant, thinking it's an analgesia, and the boy, 15 years of age, died. And I had to face some music for a couple of years. And mixing of gas cylinders has been a big disaster. A few people working in Mayo Hospital will remember. And instead of oxygen, nitrous oxide was given. You can have disasters at the hands of anesthetists or at the hands of surgeons. Look at this list, and then, for example, people have done APR for benign rectal condition, for mastectomy for a benign breast disease. Anal sphincter injuries, if you are not properly trained, can lead to incontinence. Removing carotid arteries and malignant thyroids. And one of the biggest iatrogenic surgical horror is that bilateral recurrent laryngeal nerve injury. And I have seen young people dying of this. The most common cause for a benign bile duct stricture is trauma. And I think these are the modern complications that I referred to earlier. Because untrained people doing laparoscopic procedures, particularly in the periphery, can lead to injuries to the common bile duct, and that can be an absolute disaster. What do we surgeons do in the wake of complications? Simply ignore, blame others, find faults with the instruments, blame the environment, or blame patient for not strictly following the instructions. And, once a complication occurs, few surgeons will be hesitant to explore. And not explore it at all, so that the complication is buried for good. And they don't take the relatives into confidence. I think communication skills are very important in wake of complications. They will occur at anybody's hand, but I think it matters how you deal with the relatives. Now, the other, complications would occur at your hand, your complications go elsewhere, and somebody else's complications will come to you. What do we do then? Our reaction is generally underscore the competence of the referring surgeon, which is unethical. Scare the hell out of patients, exaggerate scope of particular complication, or emphasize that you, the patient, are in the right hand now. Paint a totally black picture. At times, even incite the patient to take some legal action against surgeons performing the primary surgery. And complication of second surgical procedure also go very conveniently, in the name of the first surgery. Maybe we want to settle the old scores. Or, illogical conclusion of various inquiries. The consequences are very great. Significant morbidity, prolonged hospitalization, increased financial burden, potential litigation and occasional mortality. The potential for litigation related to this problem, especially the laparoscopic technique, is a very, very real concern to the surgeon, patient, and insurance carriers. You know, when a complication does occur, we must analyze what was the clinical situation, what has happened, and why did it happen, and how do we avoid negative events or disasters in future. I think that's the lesson one should learn from these complications. There are certain recommendations which I drew out, that complication would occur as long as surgery is. Ladies and gentlemen, with the background of the genesis of these complications, I have drawn out certain recommendations. Complications will occur as long as surgery is being performed. One has to tackle it with wisdom, courage, and at times a bit of diplomacy doesn't do any harm. One should be bold enough to shoulder and own a complication. Don't make mockery of others when you yourself are not totally safe and faultless. Passing on the buck doesn't solve the problems, and in this deceit, you may destroy some younger surgeon's career. Pray to Almighty to grant you a quick-hearted chief. Don't perform anything that you are not familiar with or without supervision. Learning is a slow process. Competency will come in your technique, but it's only a matter of time. Regular surgical audit will help you refine your techniques and hence lesser number of complications. No harm in seeking an advice from a senior, experienced campaigner. One should never be afraid of learning at any age or stage. Iatrogenic injury occurring during the casual attitude of a healthcare team, besides causing litigation problems, can even put the life of a patient at stake. Healthcare system audits by bringing some errors to the light to help and devise strategies to prevent and deal with these misfortunes. Ladies and gentlemen, with this I would like to thank you very much and congratulate the organizers for holding this conference. Thank you very much.